There is the one topic I want to present in front of you. The good morning, there is the good morning, there is evening, good evening, there is the good evening. Assalamu alaikum from my side. It's me, Dr. Mohammed Kazafi, and you are watching Dr. Mohammed Kazafi Views. And let's start our video. The topic is the slit ventricle syndrome. I want to talk about little bit about the slit ventricle syndrome. As you know, I have a case which is a 2-year-old boy is presenting with the headache and the vomiting, and the ventriculoperitoneal shunt was inserted shortly after the birth and during the prenatal period due to the history of the intraventricular hemorrhage 3 days after the birth, and the family mentioned a history of 3 previous shunt revision during the last year, and he complained of the new onset of the disabling headache and the vomiting over the past several weeks, and the neurological examination is intact. So the CT scan demonstrate here the well documented, well decompressed small ventricle compared to the previous CT scan. So here the few things are very important to discuss, and I want to put a light over it. And first of all, these type of cases, such as there, when the CT is present, definitely how I understand. Actually, this is the axial view of the CT scan with the small decompressed ventricle and a VP shunt placed in the right occipital horn on both, and no other abnormality has been identified. So I want you to define the slit ventricle syndrome. What is the slit ventricle syndrome? The purpose of the video is that this is the slit ventricle syndrome. An accepted definition for this syndrome is the combination of intermittent headache in the shunt patient and a small ventricle on imaging by CT or MRI scanning. In some articles, there is a measure used to classify the ventricular size known as the fronto-occipital horn ratio, which consists of the division of the average of maximum width of the frontal and occipital horn by the lateral diameter of the skull. The normal volume is considered more than 0.37. Can et al. Propose that the 0.2 as a reference value to define a slit ventricle. So some article, these are measure used to classify the ventricle size known as the fronto-occipital horn ratio, and which consists of the division of the average of the maximum width of the frontal and occipital horn by the lateral diameter of the skull. So this accepted definition for this syndrome is the combination of the intermittent headache in a shunting patient and a small ventricles on imaging by CT and the MRI. So the pathophysiology explanation for this syndrome, the most expected explanation for such symptom is an overdrainage of the provoked ventricle collapse and subsequently proximal catheter obstruction or malfunction, and this theory would explain the intermittent behavior of the headache because of the shunt start to work after a brief period of the malfunction due to the enlargement of the ventricles. So the Racket et al. Described the obstruction at the foramen of Monroe after the shunting due to the CSF flow inversion. This theory would be useful to explain the high intraventricular or high intracranial pressure symptom in patients with the normal or slit ventricle. Classically, it has been thought that the absence of the ventricular enlargement may be due to the diminished brain compliance in those patients. However, Shapiro et al. Showed that the pressure volume index in a normal inpatient who suffer from the symptoms of the slit ventricle syndrome, and the Engel et al. Conclude that the periventricular gliosis present in these patients could lead to an expansion failure of the ventricles with the subsequent increase of the intracranial pressure followed by worsened neurological status. However, the fact that the some of these patients treated with the lumboperitoneal shunt and showed ventricular enlargement after its insertion goes against this theory. So Benzel et al. Proposed that the increase of the venous transmural pressure in these patients could be the cause of the increased venous congestion and the higher brain elasticity that finally lead to an inability of the ventricle to expand. Another study by the Racket et al. Proposed that the increased brain turgor due to the obstruction of the venous outflow could be the explanation for the difficulty of ventricular system to reach a normal size. Albright et al. Suggested that the cause of the intracranial pressure increase is related to the premature closure of skull suture because of the lack of the skull growth stimulus, and in shunted patient, decrease of the CSF volume normally reserving skull growth simultaneous pulsation is found, and this theory could explain why some symptom of the slit ventricle syndrome patient can improve after the decompressive craniectomy, a recent hypothesis to explain the dissociation between the low intraventricular pressure and high intracranial pressure is based on the capillary laziness. So the first step in the management of this patient, the first step is to study the shunt system via imaging, CT, MRI, and the shunt series X-rays, and the consideration of the shunt tab to rule out shunt malfunction. At this point, the two possibilities exist for the because as I mentioned that the first step to study the shunt system via imaging such as the CT, MRI, and the shunt series X-rays, and consideration of the shunt tab to rule out shunt malfunction. And at this point, following two possibilities exist. One, this is a working shunt with likely overdrainage can be managed by increasing to shunt resistance via upgrading the shunt shunt valve into a higher pressure valve in case of the fixed pressure valve, or via upgrading the pressure into the higher value in case of the programmable shunt valve. A non-functioning shunt should be managed by shunt exploration and revision. In our patient case, we found a working shunt, so we choose to upgrade the programmable shunt pressure without improvement of symptom and no changes in ventricular size. So our next step to follow should be initial step by the intracranial pressure monitoring. And intracranial pressure monitoring becomes mandatory in these patients to assess if there is an intracranial hypo or hypertension. External ventricular drain placement can be used as a diagnostic and therapeutic tool simultaneously. So, as I mentioned in the first step, that the working shunt with likely overdrainage and can be managed by increasing the shunt resistance via upgrading the shunt valve into the higher pressure valve in case of the fixed pressure valve, or via upgrading the pressure into the higher value in case of the programmable shunt valve. So a non-functioning shunt should be managed by the shunt exploration and revision. And especially in our patient case, we found a working shunt. So we choose to upgrade the programmable shunt pressure without improvement of the symptoms and no change in the ventricular size. And for the next step, I did the ICP monitoring, and it became mandatory for me because I want to assess if there is intracranial hypo or hypertension. An external ventricular drain placement can be used as a diagnostic and therapeutic tool simultaneously. And the surgical treatment option here I had, such as the shunt replacement to the programmable valve with an anti-siphon device to prevent over drainage could be appropriate, or endoscopic third ventriculostomy in case where the ventricular anatomy is preferable, or the lumboperitoneal shunt insertion if there is a communicating hydrocephalus with or without programmable valve. So one should also consider the possibility of performing an EVD, and first to convert non-communicating hydrocephalus into the communicating and then placing a lumboperitoneal shunt. And in case of the uncontrolled intracranial hypertension, a decompressive subtemporal craniectomy is the treatment option of the last resort. So in patients such as lumboperitoneal shunt and contraindicated, we must know which patients are contraindicated for the shunt. So the carry type 1 and type 2 malfunction, tethered spinal cord, or those with the hydrocephalus related to the achondroplasia due to the severe spinal stenosis. So the hydrocephalus related to the achondroplasia due to the severe spinal stenosis is the definite contraindication. Then tethered spinal cord is also a contraindication, and the carry type 1 or type 2 malfunction also the contraindication. So the use of the cisterna magna peritoneal shunt is described in literature to prevent the complication related to the lumboperitoneal shunt in this group of patients. So the classification for the patient suffering from headache and having a shunt, so the Racket et al. Proposed 5 different mechanisms to explain the symptom present in this syndrome: low ICP headache, intermittent proximal catheter obstruction, shunt malfunction with a small ventricle, intracranial hypertension with working shunt, or non-related headache. So these are the symptoms, are usually different symptoms such as the low ICP headache, non-related headache, intracranial hypertension with working shunt, shunt malfunction with the small ventricle, intermittent proximal catheter obstruction. So any association, if I think there is the acquired craniosynostosis, yes, a premature skull sutural closure can be seen because of the effect of the chronic shunting in these patients, and the reduction of the cranial wall size and the acquired limited growth can cause a raise of the intracranial pressure. So these are the possibility, but I want to tell you one thing here. These slit ventricular syndromes are not very straightforward to understand, and actually this slit ventricle syndrome is not very straightforward. It is little, definitely has to develop some concept in your mind. Slit ventricle syndrome is a complication that occur after the cerebrospinal fluid shunting with a ventriculoperitoneal shunt. And this slit ventricle syndrome is a poorly defined syndrome characterized by the cerebrospinal fluid shunt-related symptoms in the setting of a small ventricle on neuroimaging. So, by definition, it is not very obvious. And slit ventricle syndrome is a rare syndrome seen in only 3 to 5% of patients with the VP shunt, and the most common cause of the ventricular shunt placement in an infant in hydrocephalus. And causes of the hydrocephalus include aqueductal stenosis, intraventricular hemorrhage, cerebral infection such as the cystic sarcosis or communicating hydrocephalus. Symptoms of the slit ventricle syndrome usually appear 2 to 5 years after shunt placement, and the average time between the diagnosis of hydrocephalus and the slit ventricular syndrome is 4 to 5 years, and the peak incidence is between 4 to 6 years. So the risk factor include small head circumference under 25th percentile. Slit ventricle syndrome can be seen concurrently with the secondary craniostenosis due to the craniosynostosis due to the skull growth derangement, and slit ventricle syndrome can also occur in adult after the ventriculoperitoneal shunt. Under normal condition, the law of Laplace states the tension equals the product of the pressure and radius. So unfortunately, with multiple cycles of the ventricular enlargement and decompression with the ventriculoperitoneal shunt, the ventricle might lose compliance and fail to enlarge with increase of the intracranial pressure. And in this case, amount of pressure necessary to increase the radius is higher because the ventricle is collapsed. Thus, the law of Laplace suggests that the patient with the slit ventricle syndrome may have shunt over drainage or under drainage. So, the slit ventricle syndrome is incompletely understood, and you know that the over drainage of the over drainage of CSF can cause collapse of the ventricle and cause intermittent shunt obstruction and cerebral hypotension. On computerized tomography imaging, slit-like ventricles can be seen, and the chronic cerebrospinal fluid shunting can cause reactionary subependymal gliosis and created proximal obstruction of the ventricle and subsequent collapse. The craniocephalic disproportion occur when the brain grows out of the proportion to intracranial volume, and this is due to early shunting through the VP shunt and overriding of the cranial suture in this pathogenesis, and the shunt function is maintained. Patient with the slit ventricular syndrome may develop intracranial hypertension to hypotension in the setting of the underfunctioning shunt or overdrainage from an overfunctioning shunt. Slit ventricular syndrome symptoms include headache, nausea, vomiting, altered mental status. However, some patient may be asymptomatic, and the clinical picture may consistent with the shunt dysfunction or shunt overdrainage. Headaches are typically episodic and last 10 to 15 minutes after associated vomiting or hyperventilation. Vital sign change of the bradycardia and hypertension may present. So headache in the slit ventricular syndrome patient can be associated with low or high intracranial pressure, and headache in the setting of the low intracranial pressure are exacerbated when the patient is upright and alleviated when lying down. And these headaches are similar in character to the post-lumbar puncture headache and may be associated with valve failure. So the headache in this setting to high intracranial pressure tends to be worse on the reclining or in the morning and can progress to all-day headache. These headaches are associated with the shunt failure without ventricular enlargement or craniocephalic disproportion in the setting of the working shunt. The complication of the slit ventricular syndrome include the subdural hematoma, hypotension, intraventricular hemorrhage, or inversion of the cortical mantle. The patient with the shunt malfunction may have visual loss due to the papillary edema or diplopia, secondary to non-colonized sixth nerve palsy in the setting of the increased intracranial pressure. Patient with the hydrocephalus may develop symptom and sign of the dorsal midbrain syndrome from increased intracranial pressure at the level of the cerebral aqueduct. Ocular manifestation of slit ventricle syndrome are congruent with ocular manifestation of hydrocephalus, which can include the visual loss, ocular mortality, abnormalities, pupil abnormalities, optic atrophy, papillar edema, cortical blindness. Although not a sensitive sign, but a papillar edema is one of the credential ophthalmological sign of shunt failure. Optic disc failure can be a sign of chronological elevated intracranial pressure with the post-papillar edema, optic atrophy. And once a patient has the optic disc failure, a sign of optic atrophy, the disc is unable to swell and the papillar edema may not manifest, therefore, even with elevated intracranial pressure. Therefore, a flat optic disc does not rule out shunt malfunction. There have been reported instances in which the slit ventricular syndrome presents solely with visual symptoms. In case reported, the visual symptoms include decreased visual acuity, color vision, and visual field. The condition can be progressed with intermittent horizontal diplopia, atrophic papillar edema, and the optic atrophy. Systemic symptoms of increased intracranial pressure may not be present and may be very minimal, for example, manifesting as headache but no nausea, vomiting, lethargy, or altered mental status. Because magnetic resonance imaging of the brain did not show ventriculomegaly in the slit ventricular syndrome, so the ophthalmic findings were initially overlooked or ministered or misinterpreted. A lack of systemic symptoms of the elevated intracranial pressure can cause diagnosis of the shunt failure to be considered delayed, and this delay in intervention can cause permanent visual loss, and thus ophthalmologists and the neurologists should be aware that the visual loss can be the initial and sole presenting sign of the ventricular shunt failure. For shunt-dependent patient, consideration should be given for the periodic ophthalmological examination for sign shunt failure. During symptomatic episode, an immediate CT of the brain and the shunt series should be performed, and the CT may show a small slit ventricle and intact shunt system. If the shunt contains pumping device, the valve will stay compressed. An assessment of the shunt and the diagnosis is usually made based on the clinical picture and imaging finding. Lumbar puncture can be performed to assess the intracranial pressure. A functional shunt study, for example, technetium scan or the contrast injection into the cerebrospinal space, can monitor flow through the CSF system and identify the location of the shunt blockade if present. A blockage shunt will have no contrast entering the ventricular system, or if injected into the shunt, the contrast will not appear in the peritoneal cavity, so the patient may also demonstrate the patient shunt obstruction, so slow flow or postural dependent flow. Medical therapy is targeted at treating the symptom of the slit ventricular syndrome, although even the treatment symptom may be refractory. And in case of the overdrainage of the slit ventricular syndrome, a programmable valve VP shunt can undergo reprogramming to reduce flow, and in patient with the shunt malfunction and slit ventricular syndrome, the VP shunt may need to replace or revise. Treatment is difficult because the attack can be severe but spontaneously subside and can be self-limiting in some patients. In patients with subacute and the chronic headache and intact shunt infection, anti-migraine medicine can be decrease the frequency and intensity of headache. Such medication include such as the cefoheptadine and the beta blocker. These medications target intracranial vessel to stabilize and decrease vasodilation, and the corticosteroid can be considered for symptomatic slit ventricle syndrome episode to decrease the intracranial pressure. And acetazolamide can be used as a temporizing measure to reduce the CSF production. But a surgical treatment alternative target increased CSF drainage or increased volume of the calvarium. The slit ventricle syndrome was traditionally managed with the subtemporal decompression. However, recurrence rate post-procedure was high, so the treatment of the slit ventricle syndrome with endoscopic third ventriculostomy plus minus shunt removal is considered more effective and decrease future complication. But EVD should be considered in patients with non-communicating obstructive hydrocephalus, block shunt, or slit ventricle syndrome. So in this procedure, a small diameter fibroscope or fiberscope with the working channel is used to pass along the ventricular catheter into the slit ventricle. An opening in the floor of the third ventricle is related to allow CSF to escape, and in patients with a slit-like ventricle and over-drainage ventricular dilatation should be considered prior to the EVD. Prognosis and outcome. One study report there is a 85% success rate of the endoscopic surgery in the slit ventricle syndrome. And in multiple studies, a majority of patients become symptom-free following surgical intervention and denying headache, nausea, vomiting, or lethargy. But the surgical complications include the VP shunt infection and intraventricular hemorrhage. These are there. But the prognostic factor in the slit ventricular patient include the patient age at shunt placement, and younger patients are at higher risk because of the hydrocephalus and mental status. I try to explain this topic in detail, and might be it is good enough, and I hope you will like it. If you like it, just subscribe and share it. Thank you. See you with one more video later.